I'm Dr. Robert Jones, and in this lecture we're going to go over how to both perform and interpret the soft tissue ultrasound for the detection of abscesses. The question we're trying to answer here is, does this patient have an abscess? There's clearly indurated skin here, there was no obvious fluctuance, but the question is, do they have an abscess? And would they benefit from surgical drainage versus just intravenous antibiotics? Let's look at the exam essentials. From a patient position standpoint, it can be variable. Depending on the location of the skin infection, you've got a lot of flexibility here. As long as you have access to the area that needs to be scanned, they can sit in whatever position is comfortable for them. In terms of transducers, since most of the abscess cavities you're going to be looking for are going to be superficial, these should be evaluated with the linear 5 to 10 megahertz transducer. In terms of patient preparation, none is required. When you perform these soft tissue exams, make sure that you use plenty of gel. This will help provide a standoff and allow better visualization of the superficial structures. It's also helpful since most of these patients are extremely tender due to their soft tissue infections. This helps to minimize transducer pressure. In patients where drainage is present, you can cover the transducer with a tegaderm or opsite, putting a thin rim of ultrasound gel on the footprint first, putting the opsite or tegaderm, and then placing Surgilube on the outside of the opsite over the footprint of the transducer. If you have access to them, hand or foot infections can be easily evaluated with high-frequency hockey stick transducers. Water bath technique can be used for the evaluation of both hand or foot infections. The affected part of the body is placed in a small tub of water, and then the transducer is inserted into the water. You only want to put the tip into the water. The advantage of this technique is that it provides a standoff between the superficial tissue, and number two, you do not have to apply direct pressure over the tender area. Starting the exam, make sure that you begin over the normal tissue. This way you have the ability to appreciate the normal anatomy, and then as you transition into the affected areas, you can appreciate the changes and the findings. In this patient, I would recommend starting here and then moving this way towards the affected area. You're going to end up scanning the affected areas in both the sagittal and transverse planes. The normal tissues are going to have the following layers. You're going to have the dermis here in the near field. You're going to have the hypodermis here. You're going to have the fascia. Deep to that, you're going to have the muscle. And then you're going to have the bone. We don't see the bone here, but we see the other layers. The muscle, fascia, hypodermis, and the dermis. The subcutaneous abscesses that we're going to be looking for are going to be confined to this region here of the dermis and the hypodermis. In cellulitis, you're going to end up seeing a cobblestoning appearance within the soft tissue. It's important to remember that this cobblestoning is a nonspecific finding and is also seen in any other condition that will cause edema of the soft tissue. Here's another patient with cellulitis, and you can see the cobblestoning in the soft tissue. This was a vein right here, but you can see the cobblestoning here, and there is no drainable fluid collection noted. It's just this cobblestoning appearance. Here's a patient with an infection of his left hand. On the sagittal view here, you can see the cobblestoning in the soft tissue here, but there is no drainable fluid collection. Again, you can see a vein coming into view right about here. On the transverse view, again, you can see some veins here, but you can see the cobblestoned appearance of the soft tissue, and here you can see the bones creating the echogenic line with the posterior shadowing. So here's a $64,000 question. Does this patient have cellulitis? This was a patient brought in on a Friday afternoon from the nursing home. They have lymphedema and chronic venous stasis, and patient's vitals are stable. They're afebrile, but they think that the leg is a little bit more red than usual. Would ultrasound be helpful here? And the answer is no. Ultrasound would be helpful to determine if there was a drainable fluid collection, but in this patient with lymphedema, there's going to be marked cobblestoning at baseline, so ultrasound would only be helpful here to rule in an abscess, not to rule out cellulitis. So let's stop and emphasize this point. Ultrasound is primarily used to determine if there is a drainable fluid collection present and cannot be used to diagnose cellulitis. This is an important point. So it's only to diagnose a drainable fluid collection, not to diagnose or rule out cellulitis. Here's a patient with an abscess cavity. Note the hypoechoic fluid collection. There's some echogenic debris in there. Note the absence of posterior enhancement. This does not meet criteria of a simple cyst. Note that the shape of it is irregular. It's not oval or perfectly round. Note that with transducer compression that there is internal swirling of the contents. These are all the grayscale findings of an abscess. It's important that when you interrogate these abscess cavities that you are able to see the entire base. If the base of it extends deep into the soft tissue and you're unable to evaluate the bottom of it, then this is a cavity that's more extensive than what you would expect and is either going to require surgical consultation for a more extensive drainage or further imaging such as CAT scan imaging or MRI. Here's a transverse scan of a patient's posterior neck. Here you can see that there is a subcutaneous abscess here. You see this complex fluid collection here. With compression, there's internal swirling of the contents. Note that you're able to follow the base posteriorly, so this is a confined subcutaneous abscess. Here's a patient that has a very tiny abscess here. There is this fluid collection here in the soft tissue, but it only measures a few millimeters. A good question is there a size cutoff where you don't need to drain that fluid collection and it can be managed medically? And nobody knows the answer to that yet. It's clear that ultrasound is much more sensitive than our physical exam, but there's no answer to if it's less than 5 millimeters, let's say, it could be managed with antibiotics versus greater than 5 millimeters requires antibiotics. Now here was a patient with a breast abscess. You can see this irregular fluid collection, internal swirling of the contents with compression. You can see that this extends deep and it was found ultimately to involve the ducts. This was adjacent to the nipple on the left breast. Once the diagnosis was made with ultrasound, this patient had surgical consultation and was taken to the operating room for drainage. Here's an example of an abscess cavity. Again, you can see this irregularly shaped fluid collection, and you can see the base of it very well. The other thing you notice in here is that there are multiple septations within here. So this is helpful to know prior to doing your incision and drainage, because this is one that you're going to have to really deloculate in order to adequately drain. Here's a diabetic male who about 4 weeks ago stepped on a nail and punctured his heel. He thought that everything was fine, said that his blood sugars have been doing well, said that he had not noticed any erythema or redness, but over the past week he's noticed redness and swelling. There's been no drainage, and he was finally urged to come in by his wife. When we performed the sagittal scan over the area by putting the transducer right here, what we saw was that there was an echogenic fluid collection. However, it was not just a simple abscess cavity. This tracked deep down, and we were unable to visualize the base of this. It turns out this patient had osteomyelitis also. The drainage on this patient was done in the operating room. Since we saw this area here that extended down into the deep tissue. We did not undertake the incision and drainage ourselves in the emergency department. So let's emphasize the point again. If you can't see the base, it's not just a simple subcutaneous abscess. You need to involve surgery, or you need to obtain further imaging in order to better define the extent of this fluid collection. Here's an abscess cavity surrounding an AV fistula. So not only is ultrasound helpful in diagnosing the presence of the abscess cavity, it's also helpful in identifying key adjacent structures. So this was one that we did not drain ourselves, but this was done in the operating room by vascular surgery. Let's take a look now at some high-risk findings. We talked about in other modules, you always want to be looking for air in the wrong places. That implies a gas-forming organism, and these patients may be sicker clinically, and these infections may spread more quickly if not treated. Here was a man that came in. He was a diabetic. He was tachycardic, febrile, and had this indurated and possibly fluctuant area in his right inguinal region. Here's the ultrasound over this patient's abscess cavity. You can see he's got this echogenic fluid collection, but look, he's got these multiple echogenic areas with dirty shadowing posteriorly. This patient has air within the abscess cavity. At one point here you can see that it's a fairly substantial amount, that it precludes any visualization posteriorly. And here it is in the sagittal plane here. Again, you can see large amount of air here. There are posterior reverberations here, and you can see the abscess cavity a little bit off to the side here. This was a patient who was taken to the operating room for his incision and drainage. There are two types of pyomyositis. There's the tropical type and the temperate type. We're going to be talking here about the temperate type, and these are usually the result of either bacteremia or trauma or injury. And staph is going to be the most common pathogen, and the treatments will include antibiotics plus surgical therapy. Here was a patient that had had a stab wound to his left bicep region. He did not seek medical care and came in approximately 10 days later with fever and erythema over the area. You can see here on this transverse view that you've got the dermis and hypodermis here. You can see that there is the fascia here. You can see the muscle deep here, and you can see that there's a heterogeneous appearance here within the muscle, and you can see that there's violation of the fascia right here. This was a patient who had pyomyositis, was taken to the operating room where he underwent an extensive drainage. Necrotizing fasciitis is a dreaded, life-threatening infection. It's usually caused by either Staph aureus or Group A strep, and these patients require both aggressive medical and surgical therapy in order to minimize morbidity and mortality. This was a diabetic who came in, had a chronic wound here, but then noticed rapid erythema and swelling, was febrile, appeared very ill, and was found to have necrotizing fasciitis. What are the sonographic findings of necrotizing fasciitis? Well, early necrotizing fasciitis can resemble cellulitis. As the infection progresses, you'll see fascial thickening, accumulation of fluid within the fascia or deep to the fascia, and the presence of air in the soft tissue may even be seen in advanced cases. It's important to remember that ultrasound cannot rule out necrotizing fasciitis. Here's the ultrasound in the patient that I just showed you. Here's a transverse view through the area. You can see that there is cobblestoning and edema of the soft tissue. You can see that the fascia is thickened here. You can see that there's fluid beneath the fascia, and you can also see that there's gas present. On the sagittal view here, you can see the same thing. You can see the presence of the fascial thickening, the subfascial fluid collection, as well as the air. And here you can see more extensive air collections and fluid. On the sagittal view, you can see the same thing. Note the marked amount of air within the soft tissue. There's a tendon right there. There's cobblestoning. So this was a patient who obviously needed aggressive antibiotic therapy, fluid resuscitation, and operative intervention. Here's the operative pictures on the patient. Note the appearance of the fascia and note how the infection extended deep into the subfascial tissue. So what are some of the pitfalls? The first thing I want to bring up here as a key point is that any hypoechoic or echogenic structure within the soft tissue could be confused with an abscess. You need to verify that there is swirling of the internal contents with transducer pressure. And if you have any doubts or if you're scanning in a high-risk area where lymph nodes may be present, I would advocate applying color Doppler to verify absence of color flow within the structure. Here is a patient that had a hematoma. It appears similar to an abscess cavity, and there's going to be swirling of the internal contents with transducer pressure. It's just that here you've got red blood cells as opposed to purulent debris. So remember, ultrasound cannot distinguish between a hematoma and an abscess based on sonographic findings alone. Here's a sagittal view of a patient who has an acute partial tear of his tibialis anterior muscle. You can see that there's a heterogeneous appearance of the muscle, but you can also see that there is a fluid collection present here. This is all a hematoma, but in the context of a patient without trauma who was febrile, you would have to look at these ultrasound findings differently. Here's a patient who has a subacute groin hematoma, status post-cardiac cath. The patient was afebrile, had no white count, and if you look here, you can see layering of the red blood cells in this hematoma here. However, in a patient who you were suspicious for infection, that they were febrile, may have a high white count, you could look at these findings completely differently. Here is a patient with a large hematoma to his anterior and medial thigh that occurred 7 days ago. It was a crush injury, and so there were several small puncture wounds. He came in 7 days later for the ED visit, febrile to 101, and had a white count at that time. Looking at the findings here, as we've just said on the previous slides, this could be due to a hematoma. You can see the layering of the echogenic portion and the anechoic portion here. These could be red blood cells. It could also be sign of infection. Since he was febrile and had a white count, he subsequently underwent ultrasound-guided aspiration. It turned out that this was all a resolving hematoma and that there was no sign of infection, but he could not be excluded based on clinical grounds or sonographic findings alone. And here's just a transverse view here of the large hematoma within the muscle cavity. I consider high-risk locations to be the head and neck, the axilla, and the groin, because here you can have, in the head and neck, you can have salivary glands, you can have lymph nodes, you can have lymph nodes in the axillary region as well as in the inguinal region. And I've seen many times over the years where necrotic lymph nodes look similar to a abscess cavity. So when I'm in these high-risk areas, I verify for the presence of compression, and I also do Doppler to verify the absence of internal color flow. Here's a patient where lymph nodes were incidentally seen during a DVT study. You can see them up here in the near field. Now, lymph nodes will have a hypoechoic outer cortex. Their inner medullary region will be hyperechoic, and you can see the hyperechoic intermedullary region and the hypoechoic outer cortex. It's important to remember that you cannot distinguish benign from malignant nodes, and enlarged nodes can either be reactive or malignant, so it should not be the part of this focus study to try and attempt to differentiate a malignant from a benign lymph node. Here's a patient with AML who has multiple enlarged lymph nodes. You can see that the lymph nodes have a hypoechoic outer cortex, and the hyperechoic intermedullary region. These all had marked increase in Doppler flow. They were non-compressible, so these should not be confused as an abscess. Here you can see increased color flow within the enlarged lymph node here, so this is clearly not something you would want to perform an incision and drainage on. Because we were up in the neck, we went ahead and put color Doppler over the area, and you could see that there was marked hyperemia surrounding the area, but there was no internal flow within this area here. But you can see on the sagittal view that there is internal flow surrounding this area here. This was a patient that had multiple matted lymph nodes, but also had one particularly enlarged node with a central area of necrosis. We did not perform an IND of this lymph node. So here's the big take-home point. If it does not compress, or if it has internal flow, then you do not want to treat this as an abscess, and you do not want to perform an incision and drainage. Here's one where a resident came to me on a busy night and said, hey, I got a simple one, got a guy with a groin abscess that needs to be opened up. Went ahead and took a look at the patient, and you could see just superior to the inguinal fold here that this patient has this markedly erythematous area. When I asked him how this started, he said that it started about 4 days ago as just a generalized erythematous area. The thing that didn't fit, this being a simple cutaneous abscess, is that there's no starting point. It wasn't a papule or an infected hair follicle. I don't see any areas to explain this being a cutaneous infection. So I went ahead and performed an ultrasound, and you can see that he's got this fluid-filled structure right here. It's got irregular borders. You can see that there's this hypoechoic area here with internal echoes. And on transverse scanning, you can see that there's some internal swirling of the contents in this region. So the question is this an abscess? Because of the location and the atypical skin findings, we went ahead and put Doppler on the area. If you look, there are areas that are devoid of color, but there is internal flow here. So right away we said that this was not a simple abscess and it was not going to be opened up. Let's take another look at this patient again. Here's the area that's markedly erythematous and swollen. It's above the inguinal fold here. You can see some erythema in this region here. If you look, there's also this area on the glands of the penis here, and it turns out, in further talking to this patient, and history is always a good thing, this patient stated that about 2 weeks ago he had this ulcer on his penis, but that went away on its own, and that's not why he was here. He was here just because of the swelling here. Turns out that this patient ended up having chancroid, and this was a bubo here. So this was basically a necrotic node here, and this was not something that you would want to do an incision and drainage on. Let me go over one other point before we end here, particularly related to head and neck, is that ultrasound can be used to evaluate the salivary glands. Tumors can be detected, but that's beyond the scope of this focused exam. But stones can also be detected, as well as inflammation of the salivary glands. Here's a diabetic male who was sent to the OMFS clinic from the medicine clinic because he'd been having dental pain, now had a fever, and had this swollen area in the left submandibular region. When he got to the OMFS clinic, it was found that his blood sugar was 529, so he was sent to the ED. It was thought that he had an abscess here that was odontogenic in origin. I went ahead and scanned this patient, and what you saw is that there is this structure here. It's not compressible, and it has these internal anechoic areas that seem to connect. You can see this central large echogenic area with shadowing. What it turns out that this patient had, we put color Doppler on. You can see these areas right here that are devoid of color. You can see that there's internal flow in here. These are the dilated ducts within the gland. This was actually a stone here, and you could see on the CAT scan that was subsequently performed that here was a very large submandibular stone causing inflammation of the gland. So this was not an odontogenic abscess and did not need to be IND'd. So this concludes the soft tissue abscess exam lecture. Dr. Robert Jones, and in this lecture we're going to go over the sonographic evaluation of peritonsillar abscesses. Let's go over the exam essentials. You're going to do this with the patient in the seated position. You're going to use the endocavitary transducer. It's going to be prepped in the same fashion that you would for the endovaginal exam. There's no patient preparation. A potential exam limitation would be if the patient has severe trismus. Here you have an exam being performed as well as a drainage. Here you've got the patient in the seated position. You've got the endocavitary transducer within the mouth. You've got the transducer sheath covering this. In terms of the sonographic findings of a peritonsillar abscess, ultrasound is actually very sensitive and specific for the diagnosis of a peritonsillar abscess. The cavity is going to have irregular borders, just like you would expect with a cutaneous abscess, and there'll be no posterior enhancement. The internal contents will swirl with compression. If you use Doppler, you may show increased flow surrounding the cavity, but that is not an essential part of the exam. And the other helpful thing is that you can identify the common carotid artery. Here's an example of a peritonsillar abscess. You've got the transducer here, so that's in the oral cavity. The indicator is directed towards the patient's right. This is a transverse exam. So you can see here, you've got some increased Doppler flow in the periphery. Here's the central abscess cavity, and you can see that with transducer pressure, there is swirling of the internal contents, just like you would see with a cutaneous abscess. Here's another example of a patient with a peritonsillar abscess. This is a transverse scan also. So you've got patient's right, patient's left. This is the anterior position within the oral cavity, and this is posterior. Here you can see the complex fluid collection here. There's some septations also. You can see the carotid vessel behind, and you can see on Doppler here, carotid vessel right there. But this was a patient with a relatively large abscess. You can see with transducer compression that there is swirling of the internal contents. On needle aspiration, about 7 cc's of pus was obtained from this patient. Here's another patient who has a very large peritonsillar abscess. You can see the surrounding area of the cavity, and you can see the central hypoechoic area with echogenic debris within it. This patient, about 7 to 8 cc's of purulent material was returned on needle aspiration. This was a transverse scan also here. Now, to do needle aspiration of a peritonsillar abscess, you can either use ultrasound guidance or ultrasound assistance. I have a tendency to use ultrasound assistance since I find it difficult to align the needle and the beam when it's within the oral cavity using the freehand technique. Here's one where I did choose to do it under ultrasound guidance, and you can see here's the needle within the abscess cavity here. I'm going from a lateral to medial direction so that I don't hit the carotid artery, but this one was done under ultrasound guidance, and about 5 cc's of purulent material was returned. Here's an abscess that was drained under ultrasound assistance. Here was the pre-drainage ultrasound, and you can see the abscess cavity here. This is a transverse scan, so anterior to posterior, patient's right, patient's left, and here's the large abscess cavity. And here is the area post-drainage. You can see that there's just a very small amount of fluid left. This patient was followed up and did very well. Let's take a look at a case real quick. Here we have a 24-year-old female who had 3 days of fever, chills, and sore throat. The sore throat is now worse on the left, and she's having a hard time swallowing. If you look, there's no trismus. She had bilateral tonsillar enlargement. Her uvula is still midline, but you notice that there's marked erythema on the left as opposed to the right, and you're starting to lose that fold here around the tonsil. So this was suspicious for a developing peritonsillar abscess. So we went ahead and performed a ultrasound. And what we saw was that the patient had bilateral tonsillar enlargement, as we saw in the clinical exam, but we also noted that there was some fluid. However, this was posterior to the tonsil. This was not something that we were going to IND or do a needle aspiration on in the ED. ENT was subsequently consulted. They recommended getting a CT scan, which again showed the fluid collection posterior to the tonsil. She was subsequently admitted to the hospital, placed on IV Augmentin, and did well after 3 days of IV antibiotics and did not require any surgical intervention. This concludes now the peritonsillar abscess lecture.